Hello and welcome to this promotional program sponsored by AstraZeneca. Thank you for taking the time today to view this presentation. My name is Dr. Richard Weissler. I'm an adjunct associate professor of psychiatry and behavioral sciences at Duke University Medical Center and an adjunct professor of psychiatry at the University of North Carolina at Chapel Hill. I'm also in private practice in Raleigh, North Carolina. As a speaker presenting on behalf of AstraZeneca, I'm here today to provide you with clinical information on Seroquel XR and its approved uses as adjunct therapy for patients with major depressive disorder and as a once-daily monotherapy for the acute depressive and manic episodes of bipolar disorder. Now let's start our presentation on differential diagnosis and treatment of major depressive disorder and bipolar disorder. We will begin by reviewing the importance of proper diagnosis of patients presenting with depressive episodes. We will then examine how the proposed mechanism of action of Seroquel XR may help explain its efficacy in both major depressive disorder and depressive episodes of bipolar disorder. Finally, we will examine the efficacy and safety data for Seroquel XR as adjunctive therapy to antidepressants for patients with major depressive disorder and as monotherapy for the treatment of acute depressive and manic episodes of bipolar disorder. First, let's review the symptoms for both bipolar disorder and major depressive disorder. Note that symptoms overlap in both disorders and may lead to misdiagnosis. The DSM-IV-TR criteria for the diagnosis of a depressive episode are shown on this slide. Remember when we discussed later slides that these criteria are the same for both major depressive disorder and bipolar disorder. Bipolar disorder is characterized by the presence of a history of manic, mixed, or hypomanic episodes, usually accompanied by the presence or history of depressive episodes. By contrast, in major depressive disorder, there's no history of ever having had a manic, mixed, or hypomanic episode. To be diagnosed with bipolar disorder, a patient must have experienced a high period of either mania or hypomania. Bipolar mania is described as an extreme high or feeling unusually great. Let's briefly review some definitions. A manic or hypomanic episode is defined as a distinct period during which there is an abnormally and persistently elevated, expansive, or irritable mood. Hypomania episodes are not severe enough to cause marked impairment in social or occupational functioning or to require hospitalization. A mixed episode is defined as the period in which criteria met both for a manic episode and for a depressive episode nearly every day. The individual experiences rapidly alternating moods such as sadness, irritability, or euphoria that are accompanied by symptoms of a manic episode and a depressive episode. Finally, I would like to point out that because diagnostic criteria for depressive episodes are the same in major depressive disorder and bipolar disorder, patients with depressive symptoms should be adequately screened to determine if they have bipolar disorder. We just saw that patients with bipolar disorder are characterized by having manic and depressive episodes. This graphic depicts a typical bipolar disorder patient that you may see in your practice. It shows that patients with bipolar disorder were symptomatic about half of the time, and when symptomatic, they spent most of their time in depressive episodes. When symptomatic, patients with bipolar disorder can spend the majority of their time in a depressive state. Let's take a closer look at the data. Data have shown that patients with bipolar I disorder spend approximately 67% of their time in a depressive episode when symptomatic, while patients with bipolar II disorder spend approximately 93% of their symptomatic time in a depressive episode. Patients with bipolar disorder are often misdiagnosed as having unipolar depression and typically require the consultation of numerous physicians before a correct diagnosis is made. In a large self-administered survey conducted in 2000, 69% of patients with bipolar disorder reported being misdiagnosed. Of these, 70% reported being misdiagnosed up to 3 times, while 26% indicated 4 or more misdiagnoses. Additionally, 68% consulted up to 4 physicians before receiving the correct diagnosis of bipolar disorder, while 26% reported seeing 5 or more physicians. The most frequent misdiagnosis was unipolar depression with 60%. Failure to recognize bipolar disorder in patients may lead to unwanted clinical consequences. Potential consequences of misdiagnosis include the delay of initiating mood stabilizers or exposure to antidepressants, which may precipitate switching into manic or mixed states or cycle acceleration in a subset of bipolar patients. It's important to note that prior to initiating treatment with antidepressants, the FDA recommends that patients with depressive symptoms be adequately screened to determine if they are at risk for bipolar disorder. To help establish a proper diagnosis, many screening tools are available, such as the PHQ-9 questionnaire for depression or MDQ questionnaire for mania, hypomania. Remember that screening should be accompanied by a thorough clinical evaluation. We've just seen that proper diagnosis is crucial for your patients and for prescribing appropriate treatment. For your patients with major depressive disorder, the APA practice guidelines include among their recommendations that for patients with an inadequate response to antidepressant therapy to either switch to another antidepressant or augment the current antidepressant. In this instance, Seroquel XR can be used as adjunctive therapy for these patients with major depressive disorder and for whom current antidepressant therapy is inadequate. For your patients with acute depressive episodes of bipolar disorder, Seroquel XR is a once-daily monotherapy proven effective for the acute depressive episodes of bipolar disorder as well as the acute manic episodes. Let's review the indications for Seroquel XR. Seroquel XR is indicated in adults for acute depressive episodes in bipolar disorder as monotherapy, acute manic or mixed episodes in bipolar I disorder as either monotherapy or adjunct therapy to lithium or divalproex, maintenance treatment of bipolar I disorder as an adjunct to lithium or divalproex, as adjunctive therapy to antidepressants in major depressive disorder, and in schizophrenia as monotherapy. Note that patients should be periodically reassessed to determine the need for treatment and the appropriate dose. When prescribing Seroquel XR for your patients, it's important that you know and understand the following information. Elderly patients with dementia-related psychosis treated with atypical antipsychotic drugs are at an increased risk of death compared to placebo. Seroquel XR is not approved for the treatment of patients with dementia-related psychosis. Antidepressants increase the risk of suicidal thinking and behavior in children, adolescents, and young adults in short-term studies of major depressive disorder and other psychiatric disorders. Patients of all ages started on therapy should be observed closely for clinical worsening, suicidality, or unusual changes in behavior, especially during the initial few months of drug therapy or when changing dose. And Seroquel XR is not approved for use in patients under the age of 18 years. We have seen that depression is common to both major depressive disorder and bipolar disorder. Let's now examine what could be the underlying cause of depression. The exact pathophysiology of depression remains unknown. However, the three main monoamine neurotransmitters present in the brain, dopamine, norepinephrine, and serotonin, have been associated with depression through the monoamine deficiency hypothesis, which is one of the hypotheses that's been proposed to explain depression pathology. This hypothesis proposed that the underlying cause of depression is the deficiencies in the levels of serotonin, norepinephrine, and/or dopamine in the brain. The hypothesis is partially derived from the mechanism of action of currently available antidepressants. Studies have shown that increasing any of these three neurotransmitters elevate mood, while decreasing their levels may exacerbate depression. Dopaminergic, noradrenergic, and serotonergic systems all interact with each other, and some or all of these pathways may mediate expression of depressive symptoms in both major depressive disorder and bipolar disorder. Serotonin and norepinephrine transporters are important components of the monoamine pathways. Balancing activity at both of these transporters is a key determinant in the therapeutic properties of drugs targeting these monoamine transporters. The mechanism of action of Seroquel XR, as well as other drugs having efficacy in the treatment of bipolar disorder and major depressive disorder, is unknown. The active metabolite norquetiapine has similar activity at dopamine D2 receptors, but greater activity at serotonin 5-HT2A receptors than the parent drug quetiapine. The efficacy of Seroquel XR in depressive episodes of bipolar disorder and major depressive disorder may be partly explained by the high affinity and potent inhibitory effects that norquetiapine exhibits for the norepinephrine transporter. It's been proposed that the efficacy of Seroquel XR in schizophrenia is mediated through a combination of dopamine D2 and serotonin 5-HT2A antagonism. Antagonism at receptors other than dopamine and serotonin with similar greater affinities may explain some of the other effects of quetiapine and norquetiapine. Note that antagonism at histamine H1 receptors may explain the somnolence, while antagonism at adrenergic alpha-1b receptors may explain the orthostatic hypotension, and antagonism at muscarinic M1 receptors may explain the anticholinergic effects. When looking at both quetiapine and norquetiapine, you can see that they both have affinities for multiple neurotransmitter receptors, including dopamine D1, D2, serotonin 5-HT1A and 5-HT2A, histamine H1, muscarinic M1, and adrenergic A1B and alpha-2 receptors. Quetiapine differs from norquetiapine in having no appreciable affinity for muscarinic M1 receptors, whereas norquetiapine has high affinity. Both quetiapine and norquetiapine lack appreciable affinity for benzodiazepine receptors. Let's now review clinical trial data for Seroquel XR as adjunctive therapy to antidepressants in patients with major depressive disorder. Seroquel XR efficacy and safety was evaluated in two 6-week, multi-center, double-blind, randomized, parallel group, placebo-controlled, double-dummy, phase 3 trials. These trials included 939 patients with major depressive disorder who had an inadequate response to their current antidepressant therapy. They received Seroquel XR 150 milligrams per day, or Seroquel XR 300 milligrams per day, or placebo, in combination with their current antidepressant. The primary efficacy outcome variable for both studies was mean change from randomization to week 6 in the Montgomery-Åsberg Depression Rating Scale, or MADRS. Total score in patients receiving Seroquel XR in combination with an antidepressant versus receiving an antidepressant alone. In the study by El Khalili and colleagues, seen in the graph on the left, Seroquel XR 300 milligrams per day plus antidepressant demonstrated significant improvement in mean MADRS total score versus placebo plus antidepressant at week 6. Patients receiving Seroquel XR decreased their MADRS total score by 14.7 points versus a reduction by 11.7 points for placebo. The p-value was less than 0.01. Seroquel XR 150 milligrams per day plus antidepressant did not achieve statistical significance when compared with placebo plus antidepressant at week 6. The Bauer study seen in the graph on the right showed that at 6 weeks, both Seroquel XR 150 milligrams per day plus antidepressant and 300 milligrams per day plus antidepressant reduced MADRS total scores by 15.26 points and 14.94 points respectively. The reduction in the placebo plus antidepressant group was 12.21 points. The difference between the two Seroquel XR doses and placebo were significant, with p-values less than 0.01 versus placebo for both treatment groups. Let's now review the data for Seroquel XR in patients with bipolar disorder. First, in patients with bipolar disorder presenting with acute depressive episodes, a single clinical trial evaluated Seroquel XR efficacy and safety. It was an 8-week, multi-center, double-blind, randomized, parallel group, placebo-controlled phase 3 study. The study consisted of a screening enrollment, a washout period of up to 35 days to discontinue all prior psychotropic medications, and an 8-week treatment period with one of 2 treatment regimens, either Seroquel XR 300 milligrams given once a day in the evening as monotherapy or placebo. The primary efficacy outcome variable was the mean change from randomization to week 8 in the MADRS total score. Seroquel XR monotherapy demonstrated significant improvement in the mean MADRS total score versus placebo as early as week 1 and continuing through week 8. It's important to note that these results reflect the use of Seroquel XR alone and not in conjunction with other therapies. MADRS total score is decreased for both patients treated with Seroquel XR and patients treated with placebo. The mean MADRS total score at week 8 for patients receiving Seroquel XR was reduced by 17.4 points from baseline compared to 11.9 points for placebo. The difference was significant with a p-value less than 0.001. This reduction clearly demonstrates the antidepressant efficacy of Seroquel XR for patients with acute depressive episodes of bipolar disorder as monotherapy. Seroquel XR efficacy and safety has also been examined in a phase 3 clinical trial in patients with manic or mixed episodes associated with bipolar I disorder. In this 3-week multicenter randomized double-blind placebo-controlled monotherapy trial, Seroquel XR significantly improved manic symptoms at day 4 and maintained improvement through the end of week 3. Seroquel XR was flexibly dosed from 400 milligrams per day to 800 milligrams per day with a mean dose of approximately 600 milligrams per day. The top figure shows mood improvement in this 3-week trial. There was a 50% reduction from baseline to week 3 in the mean Young Mania Rating Scale, or YMRS, total score for Seroquel XR monotherapy. For the placebo group, the reduction was only 37%. Let's go back for a minute to the 8-week monotherapy trial in patients with acute depressive episodes associated with bipolar I and II disorder. In this trial, Seroquel XR 300 milligrams per day significantly improved depressive symptoms at week 1 and maintained improvement through the end of week 8. The bottom figure shows mood improvement in this 8-week trial. There was a 58% reduction from baseline to week 8 in mean MADRS total scores for Seroquel XR monotherapy. For the placebo group, the reduction was only 40%. Let's now review the dosing recommendations for Seroquel XR. For major depressive disorder, the recommended dosing for Seroquel XR as adjunctive therapy to antidepressants is to begin with a 50 milligram dose daily. On day 3, the dose can be increased to 150 milligrams daily. After day 4, the dose can be titrated to the recommended dose range of 150 to 300 milligrams per day. In major depressive disorder clinical trials, there were dose-dependent increases in adverse reactions in the recommended dose range of 150 to 300 milligrams per day. The recommended dosing for Seroquel XR as monotherapy in acute depressive episodes of bipolar disorder is to begin with a 50 milligram dose on day 1, then 100 milligrams on day 2, 200 milligrams on day 3, and 300 milligrams on day 4. Please note that the recommended daily dose for Seroquel XR in acute depressive episodes of bipolar disorder is 300 milligrams. Remember also that Seroquel XR is recommended to be taken in the evening, within 3 to 4 hours before bedtime, without food or with a light meal of approximately 300 calories. Note the following key considerations when dosing Seroquel XR for your patients. In the elderly and in patients with hepatic impairment, consideration should be given to a lower rate of titration, careful monitoring during the initial dosing period, and a lower target dose. Patients should be periodically assessed to determine the need for treatment and the appropriate dose. Seroquel XR tablets should be swallowed whole and not split, chewed, or crushed. Seroquel XR may induce orthostatic hypotension with associated dizziness, tachycardia, and syncope, especially during the initial dose titration period, and should be used with caution in patients predisposed to hypotension or with known cardiovascular or cerebrovascular disease. Since Seroquel XR has the potential to impair judgment, thinking, or motor skills, patients should be cautioned about performing activities that require mental alertness, such as driving or operating hazardous machinery. Patients should be advised to avoid consumption of alcohol and avoid overheating and dehydration during treatment with Seroquel XR. Now we will turn our attention to a closer examination of the safety data for Seroquel XR. as adjunct therapy for major depressive disorder and as monotherapy for the treatment of both poles of bipolar disorder. First, let's take a look at the most common adverse reactions for Seroquel XR that were observed in clinical trials of major depressive disorder. They included somnolence, dry mouth, fatigue, and constipation. In the clinical trials, 12.1% of patients on Seroquel XR discontinued due to adverse reactions, compared with 1.9% on placebo. The most common adverse reaction for Seroquel XR that were observed in the trial of acute depressive episodes in bipolar disorder included somnolence, dry mouth, increased appetite, weight gain, dyspepsia, and fatigue. In this trial, 14% of patients on Seroquel XR discontinued due to adverse reactions, compared with 4% on placebo. Finally, the most common adverse reaction for Seroquel XR that were observed in the acute manic episodes of the bipolar disorder trial included somnolence, dry mouth, dizziness, constipation, and weight gain. In the trial, 4.6% of patients on Seroquel XR discontinued due to adverse reactions, compared with 8.1% on placebo. We will now review some additional important safety information for Seroquel XR. The most commonly observed adverse reactions associated with the use of Seroquel XR in clinical trials across all indications were somnolence, dry mouth, constipation, dizziness, increased appetite, dyspepsia, weight gain, fatigue, dysarthria, and nasal congestion. Neuroleptic malignant syndrome, or NMS, a potentially fatal symptom complex associated with hyperpyrexia, muscle rigidity, altered mental status, and autonomic instability, has been reported and associated with administration of antipsychotic drugs, including Seroquel XR. The management of NMS should include immediate discontinuation of antipsychotic drugs, intensive symptomatic treatment, medical monitoring, and treatment of concomitant serious medical problems. Hyperglycemia, in some cases extreme and associated with ketoacidosis, hyperosmolar coma, or death, has been reported in patients treated with atypical antipsychotics, including Seroquel XR. Patients starting treatment who have or are at risk for diabetes or who develop hyperglycemia symptoms should undergo fasting blood glucose testing before and during treatment. Any patient treated with atypical antipsychotics should be monitored for symptoms of hyperglycemia, polydipsia, polyuria, polyphagia, and weakness. Undesirable alteration in lipids have been observed with Seroquel XR use. Increases in total cholesterol, LDL cholesterol, and triglycerides, and decreases in HDL cholesterol have been reported in clinical trials. Appropriate clinical monitoring is recommended, including fasting blood lipid testing at the beginning of and periodically during treatment. Increases in weight have been observed in clinical trials. Patients receiving Seroquel XR should receive regular monitoring of weight. In some patients, a worsening of more than one of these metabolic parameters of weight, blood glucose, and lipids was observed in clinical trials. Changes in these parameters should be managed as clinically appropriate. Tardive dyskinesia, or TD, a potentially irreversible syndrome of involuntary dyskinetic movements, may develop in patients treated with antipsychotic drugs. The risk of TD and likelihood of irreversibility increases with the duration of treatment and total cumulative dose. However, TD can develop at low doses or after treatment has been discontinued. TD may remit if antipsychotic treatment is withdrawn. Seroquel XR should be prescribed in a manner to minimize the occurrence of TD, and treatment should be discontinued if signs or symptoms of TD occur. Leukopenia, neutropenia, and agranulocytosis, including fatal cases, have been reported temporally related to atypical antipsychotics, including Seroquel XR. Patients with a pre-existing low white blood cell count or a history of drug-induced leukopenia or neutropenia should be monitored frequently, and Seroquel XR should be discontinued at the first sign of decline in white blood cells. Seroquel XR should be discontinued in any patient if their absolute neutrophil count is less than 1,000 per cubic milliliter. Lens examination for cataracts is recommended when starting treatment and at 6-month intervals doing chronic treatment. Increases in QT interval have been observed in post-marketing reports in patients who overdose on quetiapine, in patients with concomitant illness, and in patients taking other medicines that cause electrolyte imbalance or increased QT. Avoid use of Seroquel XR with drugs that increase QT interval, and in patients at risk for prolonged QT interval. Use Seroquel XR cautiously in patients with a history of seizures or in patients with a potential for a lower seizure threshold, for example, Alzheimer's dementia. Disruption of the body's ability to reduce core temperature has been attributed to antipsychotics. Care is advised for patients who exercise strenuously, are exposed to extreme heat, are taking medications with anticholinergic activity, or are subject to dehydration. Esophageal dysmotility and aspiration have been associated with antipsychotic use. Use caution in patients at risk for aspiration pneumonia, a common risk of morbidity and mortality in elderly patients. Suicide attempts are inherent in schizophrenia, bipolar disorder, and depression, and close supervision of high-risk patients should accompany drug therapy. Warnings and precautions also include the risk of hypothyroidism, hyperprolactinemia, transaminase elevations, priapism, and withdrawal. Please see full prescribing information, including box warnings, for more information. To summarize, let's review some key points from this presentation on Seroquel XR. Remember that proper diagnosis of bipolar disorder is critical. Misdiagnosis of depressive episodes of bipolar disorder is frequent and can potentially have negative consequences. Patients with depressive episodes should be screened for bipolar disorder. While its mechanism of action is unknown, it has been proposed that the efficacy of Seroquel XR in major depressive disorder and acute depressive episodes of bipolar disorder may be partly explained by the high affinity and potent inhibitory effects that norquetiapine exhibits for the norepinephrine transporter. Seroquel XR is proven effective as an adjunct therapy to antidepressants for patients with major depressive disorder. Seroquel XR is a once-daily monotherapy proven effective for the treatment of acute episodes of both poles of bipolar disorder. Seroquel XR 300 milligrams per day has demonstrated significant efficacy as monotherapy in acute depressive episodes of bipolar disorder as early as week 1, continuing through week 8. Finally, Seroquel XR flexibly dosed between 400 and 800 milligrams a day demonstrated significant efficacy as monotherapy in acute manic episodes of bipolar disorder as early as day 4, continuing through week 3. Before concluding this presentation, we'll take a moment once again to review the indications for Seroquel XR. Seroquel XR is indicated in adults for acute depressive episodes in bipolar disorder, acute manic or mixed episodes in bipolar I disorder as either monotherapy or adjunct therapy to lithium or divalproex, maintenance treatment of bipolar I disorder as an adjunct to lithium or divalproex, as adjunctive therapy to antidepressants in major depressive disorder and schizophrenia. It is important to note that patients should be periodically reassessed to determine the need for treatment and the appropriate dose. Thank you for viewing this presentation. We hope you found it to be informative. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have any comments that could improve the delivery of our promotional educational programs, please contact AstraZeneca at 1-800-236-9933.